Hello, Overcomers, and welcome to this episode of Connect Over Coffee. I'm Runsi, the founder of Overcome, and today we have our champion and a true world leader in ovarian cancer, Dr. Shannon Westin. So, Dr. Westin is professor and director of Gynecologic Oncology Center at MD Anderson Cancer Center, and she is the principal investigator of multiple novel treatment trials for gynecologic cancers. Dr. Westin is globally recognized as a tremendous expert in ovarian cancer, a true champion of Overcome. As our Leadership Council member, Dr. Westin always shares her tremendous knowledge with us in honor of all our overcomers worldwide. So join us for the next 45 minutes to an hour as we chat with Dr. Westin about all things ovarian cancer. Have your coffee ready. I have mine, and let's connect over coffee. And there you go.
Oh, wait, you can't see it. There it is. I have my coffee.
There
I'm very festive today.
That's fantastic. And so if you have any questions as we go along, please type in the comment sections below and we will get it addressed, try to get it addressed post the discussion. And as I always say, please share this video far and wide with anyone who may benefit from all these great insights Dr. Westin is about to share with us. So with that, a huge welcome back to you, Dr. Westin, to this episode of Connect Over Coffee. You feature on all our seasons, so you're clearly our favorite. So welcome back.
Well, thank you. It's always a pleasure to chat, and I look forward to a really great discussion today.
Thank you, Dr. Westin. So speaking of great discussions, I'm going to ask you about the statement you made. So it says a little bit of excitement, a little bit of competition, maybe, but lots of options for our patients. Tell us more about this statement.
Sure. I think we were, at the time we were discussing just where things are going for patients with ovarian cancer, what options we have. And, I think the statement basically stemmed from, we're seeing lots of exciting data coming out, some small studies, some bigger studies, and a lot of potential new approvals. And so I think, with that, when we see that much great data coming out and we see that many great outcomes coming for our patients, it's of course very exciting, right? We want to move the needle. We want to push things forward. And I think because there are certain targets that are catching fire in ovarian cancer, and of course we've talked about PARP a lot, but these are new targets, new drugs, new options. There's a little competition to get into the space as quick as possible and to, get the biomarkers figured out and get the side effects figured out and get the efficacy figured out so we can, get the drugs to our patients. And so I think that was where that statement came from. And certainly I think shows my enthusiasm for what we're being able to do right now in drug development.
That's a wonderful start to the discussion and a great segue into my next question. So my question was, tell us about the biomarkers, right? And how are they utilized to predict response and recurrence in gynecologic cancers? And how many types of biomarkers are there now and evolving when it comes to ovarian cancer?
Sure. I mean, I think, depending on the gynecologic cancer, we have a lot of different kind of progress, right? So I think arguably the gynecologic cancer with kind of the best biomarkers right now is endometrial cancer, where we've seen a ton of work with the Cancer Genome Atlas that identified that all endometrial cancers were not created equal. And in fact, there were 4 major types based on the molecular aberrations that were found. And in fact, there are groups that have done a really great job of trying to identify each of these 4 molecular groups with arguably a simple test. And the reason I say arguably is because some of that testing involves pretty extensive molecular testing called next generation sequencing, which can be expensive and hard to maybe get out to everybody across, the world, like across countries, developing countries and others. And so it's exciting, and the data are evolving around how we can use that testing for not only prognosis, but perhaps even making pragmatic choices about treatment. So I think that's kind of the bar that we're looking to set. As far as ovarian cancer is concerned, obviously the presence of BRCA mutations and utilizing the homologous recombination deficiency testing has been I think obviously BRCA has been being done for quite a bit of time. The HRD testing is moving along, but we're still really working on exactly what that means for our patients. They certainly seem prognostic. BRCA is clearly predictive for benefit from PARP inhibitors, and HRD to some degree is as well, but not as much as BRCA. So there's still, I think, some room for improvement of that test. But I think what's exciting about for ovarian cancer for biomarkers are the developing drugs that are not yet necessarily available to our patients yet. We have high hopes that they will be. And many of those do involve testing for a specific target or a specific biomarker. And so the thought process being, if a patient has that specific target or biomarker in her tumor, then this drug may work better for her, or may only work for her. So I think that's the kind of exciting place for biomarkers right now. A lot of the trials that are exploring these drugs are working out how to do the testing at the same time. So you're seeing kind of co-development of drug and test. And so as these drugs maybe show efficacy and hopefully get approved, then it will be important to also get that testing out so we can identify those patients as quick as possible and give them this new novel drug if it's appropriate.
Wonderful. So, and fortunately for majority of our patients, there seems to be a lot happening in the platinum resistant space. And you are at the forefront or at the center of it, of all this great, progress ongoing. So what are you most excited about when it comes to platinum resistant ovarian cancer, and why?
So that's what we're going to spend the rest of the time talking on, right?
Yes,
It's
yes.
like a 40-minute discussion. No, so I will keep it brief, but I think there's some major areas that are of interest or excitement, right? So one are the antibody drug conjugates. And so this is a class of drugs. This is what I was getting at with the biomarker testing. And I'll just give a quick rundown on what they do. They're a really cool mechanism. They're basically a targeted high dose chemotherapy. And so what you have is a lock and key mechanism where the drug is a key that looks for a specific lock on the tumor. And when they find themselves, it connects. And then it's basically like a Trojan horse, where when that lock and key happens, the cancer cell pulls in the drug internal to the cancer cell, and then it releases a high dose chemo, way higher than we could ever give by IV. It would be too toxic. And so we get this focused high dose chemotherapy inside the cancer cell, and it implodes. And then you even get a little bit of bystander effect, meaning if a cell wasn't maybe expressing that lock as much, it will still potentially get hit by that chemo. So it's a really cool, like, dual mechanism of action. And obviously, it seems to be the next step in precision medicine, where you're identifying, okay, who has the lock, and then giving them the drug. And so there are a number of different targets that are under exploration. The drug that's the farthest along that you may have heard of is mirvetuximab, which is targeting folate receptor alpha is the lock. And so that drug is under review right now at the FDA based on really nice results in the phase 2 studies that have been done, and a confirmatory study is also being completed. And so the hopes are that it will get an accelerated approval followed by confirmation. Other targets that have been really interesting that we're seeing kind of early data on are a target called NaPi2b. There's a target called TROP, and a target called B7H4. And this is not by any means all of them, but these are some of the ones that are most exciting, I would say, for gynecologic cancers, and specifically ovarian cancer. And really what, I think a lot of us are hoping is to be able to do some type of panel where we check for all of these different locks and then say, okay, for you, you get this drug, and for you, you get this drug. And right now, all of the activity has been in the platinum resistant space for these drugs. Although I will say, if these are positive, they will likely do what all good drugs do and move earlier, with the goal of curing more patients and not having the development of platinum-resistant disease. So I think that kind of class of agents is really exciting. The other thing I would just mention is that we're seeing a lot of interest around immunotherapy, right? And we've talked about immunotherapy before, that some of the, first generation immunotherapies, so-called checkpoint inhibitors, haven't been that great for ovarian cancer. And so there's a number of different, combination strategies that are being explored. But something that's really been interesting is the utilization of adoptive cell therapy. And so adoptive cell therapy is when, again, we have a target on a cell, right? And so we can take out the fighting T cells, the fighting immune cells, and we engineer them to make them smarter, faster, stronger. Mm-hmm. And then we put them back into the patient with that scent, like a drug sniffing dog, basically. So again, this involves a biomarker that those cells are looking for. And so to qualify for any one of these adoptive cell therapies, the tumor has to express that lock. Okay. And once we have that sense, then that may work very well. And, CAR T cell therapy has been great for, lymphomas. My husband can talk about that for hours, but for solid tumors, it's been less exciting. And so we're finally starting to see some exciting data towards targets like PRAME and MAGE-A4, where we're seeing these drugs go into phase 3 studies for ovarian cancer. And so again, getting at a better precision medicine, in this case, precision immunotherapy, which would be, a wonderful option, and certainly is something that's being explored in platinum resistant disease as well. And then I think the last, not the only other thing, but the last thing I'll mention is, some novel takes on what we're already doing. So, novel anti-angiogenics. I think many of our listeners are familiar with like bevacizumab and how it targets the bad blood vessels. So there's a number of new drugs that are looking to kind of take that to the next level and overcome resistance in this space. And similarly, everybody here has heard about PARP inhibitors. Those are DNA damage repair agents. And there's a number of really cool drugs that are in that space that are hoping that in situations where PARP doesn't work or PARP has failed a patient, can we utilize a new drug in this space and potentially offer other opportunities. And so I think there's a lot going on, and it is certainly very exciting. And so hopefully over the next few years, we'll see a lot of new approvals and a lot more precision medicine for the patients.
So thank you for the great discussion and clarifications, but a few questions follow up to what you just said, that for patients that these are, from what I understand, for platinum resistant, right? So with all these options coming in for the platinum resistant patients, how would you kind of choose the patients?
Mm-hmm.
Like who gets what kind of treatment? How would you do that going forward? And then we received several questions and requests throughout the course of, a month or a week that, there are clinical trials open, especially in immunotherapy, where patients are interested to sign up on clinical trials. However, there are only 13 openings, or there are, very few and very limited, or it is always said that your provider can determine whether or not you can sign up for this clinical trial. So there are still a few barriers to getting there. So help us navigate that a little bit by, answering first of all, how would you classify these patients and select them based on all these this resistant treatment options coming forward? And then in terms of particularly for immunotherapy clinical trials, how can we make it easier for our patients to kind of enroll or at least get in the process?
Yeah. So I think, in regards to choosing what's best, a lot of it is going to depend on the tumor, right? So many of these new drugs really need a target, right? So for example, the antibody drug conjugates, a lot of them are selecting based on whatever the lock is.
Right.
For the DNA damage repair agents, although we are broadly looking across all patients, we do expect them to work better in patients with specific mutations in that pathway, like BRCA or ATR or ATM or things like that. So there may be opportunities to use kind of what's going on in the patient's tumor to be able to guide those things. And I think if we're lucky enough to have all these drugs come into practice, then it'll be just like how we decide between a PARP inhibitor or something else, right? Who's in front of you, what's the schedule like? Is it an IV infusion versus a pill? What are the logistics involved, and what does the patient prefer as far as the side effect profile and what the risks are? So I think that'll be like, I think I would love to be having those conversations. If I've got like 4 drugs that are an option for my patient, I will be very happy. We'll be happy to kind of discuss kind of which one's better at any given time. As far as clinical trials, it is very hard, especially with some of these more advanced immunotherapy trials. When they first start, they really are just in a select group of patients, because we want to make sure that they're not too toxic, and we want to see if there's an early signal. But, for example, some of the CAR T cell therapies are now moving forward in large phase 3 trials. So that's going to open it up for a large proportion of patients. But again, there's going to be testing involved, and we have to see if it's the right choice for that patient, right? So I do understand the struggle from the patient side, but I think it's important to know that it's really born out of an interest in keeping people safe and not treating too many people with either a drug that's toxic or a drug that doesn't work. So, there's a method to the madness that, we start with a smaller group because we don't want to waste people's time. And it can be super frustrating as a patient because you want access to the, newest agents as soon as possible, but you have to trust the process and hope that if that drug is effective, that you'll get access to it if you didn't on an early trial. The other thing I would say is, as much as you're able, getting involved with a center that, does research, right? And that can be either a comprehensive cancer center or, there are also, excellent community programs where they do tons of trials. And so if you're in a facility where there aren't a lot of trials, then, ask your doctor, well, is there somebody local? Because I get it. Not everyone can fly to Houston or Memorial in New York or, Boston or wherever, but likely there is a GOG Foundation site near you. And often we see patients from all over the country in Houston, but we end up putting them on trials somewhere closer to home, because we can help them kind of say, okay, this trial is really a great option for you, and you can get it 2 hours away. Because for me, I just want patients to get access. I don't need them to be treated by me. I like them to be treated by me, but I'm well aware that not everyone lives in Houston and travel is expensive and we're away from family, et cetera. So there's a lot of other costs, right? So, getting access to a center that has trials, they can often help you find, other sites if they don't have a particular trial that makes sense for you.
Yeah, and that is so important because, especially the new and upcoming trials and the work that you just mentioned, these seem to be very sophisticated, which is fantastic. But I mean, I sometimes have concerns as to whether the community center hospitals will even know about these things, in real time. So it's important to stay connected with what's ongoing, what's coming up, so that the patients can ask informed questions. So thank you, Dr. Westin. And we, again, great segue into my next question. I was going to ask you about the promising clinical trials that you are running, and what is exciting about them, and what do you want our overcomers to know, and how can they enroll in the trials that you may be running in this space?
Yeah, I mean, I think, again, this is another question that could take the whole rest of the discussion. But I think that that we have a number of really interesting things. I think, I'll highlight my colleague first. Dr. Jaziri is doing quite a bit of innovative immunotherapy along those lines of what I just mentioned with the adoptive cell therapy, those CAR T cells, where we, re-engineer your fighting immune cells to fight your cancer. And so he's been really leading the way with that, as well as using something called tumor infiltrating lymphocytes, where we actually take out the fighting T cells from your tumor. So we know they're smart and they found the tumor, and then we multiply them and put them back in to fight. So he's done a lot of great work with that. As far as other trials that we have right now, for patients with BRCA mutations or HRD that have had PARP inhibitors and subsequently experienced a recurrence, we have an option to try to resensitize those tumors to PARP utilizing ATR inhibitors. And so we give a combination strategy in that space. And we're seeing a lot of exciting outcomes there. And that trial is still actively enrolling. We have another trial that's just about to open that I think a lot of our overcomers have heard about because we get calls about it on the daily. This is a collaboration with Rice University, where they had a really very cool basically technology where they can engineer agents to express specific, they engineer these basically little tiny
the drug factory implants.
Yeah. So I'm sorry, I'm having a break, but it's basically like these little kind of circles. and I wish I could show you a picture.
Yes, they are called the drug factory implants.
Well, yeah, it's an encapsulated cell therapy, and basically they take regular cell lines and then they can express something, right? And so they can use a number of different, they can express a number of different targets. But there are these basically little capsules that get injected. And I'm sorry, I couldn't think of the word capsules for some reason. Go figure. But they get injected at the time of a laparoscopic surgery, and then they are absorbed into the tumor cells. And specifically, the drug that's the farthest along expresses something called IL-2.
Yes,
which is it was a cytokine and has been known to be very toxic to cancer cells. But unfortunately, when we give it systemically or IV, it's very toxic to humans. And so it's really hard to get an adequate dose that will fight cancer that doesn't, make people miserable or very sick. And so what this does is it's basically this encapsulated cell that really then starts to express IL-2 and kills the cancer cell once it's been absorbed. So it's very interesting. It's very cool. It is about to open and will be one of the sites where we'll be the first site to open. But it's really unlike anything that we've ever done before. And so we're very enthusiastic about it. And in fact, Rice did such a great job of advertising that we've had multiple patients like, when is it opening? When is it opening? And so, so hopefully soon, like in the next few weeks. So I think that's another really kind of novel thing that we've been collaborating on that we're really excited about.
That's wonderful, because Omid, who is the PI for this for this particular trial, Omid has actually spoken at one of our events, and he has also been an episode guest at Connect Over Coffee. I have visited his lab, have seen all those capsules that he's kind of working on. So yes, I mean, our overcomers are supremely excited about this particular trial because it seems like it can be a really good option for patients, particularly for the ones that have possibly exhausted the options per se. So I was very excited to know that you are leading, you're the clinical lead for this trial, because we have high hopes on this one, and I hope everything goes well, because it is very promising. So thank you for sharing more information on that. And I know that we will get more questions from our overcomers how they may enroll. And so overcomers will keep updating you with information on this particular trial as we go along. As you know, Dr. Westin is leading this now with Dr. Vesa. So it's all good, going to be great. So Dr. Westin, my next question is that, as we are talking about clinical trials, we also understand that they may come with some side effects, right, for each patient, and we understand they're advised to review the information before they commit to it. So from your experience in running so many of these trials, what guidance would you give to our overcomers as to, kind of best preparing for the clinical trials and decide whether or not this is right for them based on the possible results or the side effects?
Yeah, I mean, I think it really comes down to ensuring that the informed consent process is appropriate and making sure that you get all the information you can. Most sites, when they're discussing a trial with you, will, one of the biggest pieces is, what's the chance of benefit? Like, why this trial for you, right? So why is this the right choice? And again, is that biomarker based? Is that, just that there's platinum sensitive disease, platinum resistant disease? Like, what is the expectation for benefit? And then how much is known about toxicity, right? So there's going to be varying degrees of knowledge about what's expected based on where that trial is, right? So for later phase trials, the drug has been used quite a bit already, right? And it's going for its final approval. And so you should really get a pretty thorough discussion of the expectations of side effects, down to like 10% of patients have this, more than 20% of patients had this. So you can really get kind of nitty gritty. For some of the earlier phase trials, it's going to be more, this is what we anticipate based on what happened in, testing with animals and things like that, right? And so obviously we use these animal models to know what potential toxicities to anticipate when we treat patients, when we treat humans, but there's some unknowns. And so understanding exactly how early that drug is in development and what the potential risks are. But for example, this drug we just talked about, the encapsulated IL-2, I mean, this has not been used in humans at all, but in animals the side effect profile was awesome. The toxicities were minimal, and so the expectation is that will be the same, but there's some unknown. But of course, based on what we see in the early preclinical studies of that drug, we anticipate this is potentially a game changer for patients. And so weighing, that. And some patients may say, you know what, I don't want to be the first patient to get something. And that's okay, right? You have to feel comfortable. I can guarantee you there will be somebody that will want to be that patient. So I think that it's just a matter of kind of where you are. And we often talk about, when we talk about new innovations of any kind, and that can be out of medicine too, right? We talk about there are early adopters, and then, there are people that kind of need to see more data and everything. That same goes for new drugs, right? So it really comes down to a personal decision around, what are those risks? How much is known? And, what are you willing to kind of accept? I think also from, clinical trials outside of adverse events and toxicity, you also have to consider the commitment, right? So what is it going to involve for you on a day-to-day, week-to-week basis? How many visits, how many blood draws, how many EKG, what's involved, how many biopsies and things like that, and making sure you understand why you need to get all those things and that you're willing to do that. And that especially comes true, for if you don't live in the city where you're getting treated, right? And we see this a lot in Houston. So we make sure that patient has a clear calendar and understands when she and her family are going to need to come back and forth, and how long those trips are going to take, and that way they can determine if that's something that they can invest right then and there. And of course, it's always nice when trials pay for transportation and things like that, but that's not always possible. And so it really is, an investment of time and resources sometimes to go on some of these. And that's why I mentioned before, we're always interested, if we've got a trial that's open in multiple sites, to try to get a patient on at a site that's closest to her and her family so that it can be as convenient as possible.
And thank you, Dr. Westin, for breaking it down for us. But I'll say that, one thing that you have always emphasized on, and I think it's important for us to, again, re-emphasize, is the safety and the efficacy of the trials. I mean, even though you are signing up as an early adopter, you are certainly not risking your life per se, because of the way the trials are designed and how it's monitored. Like you always say, that if it is not working well for a particular patient, we make sure that she gets off the trial immediately without any harm. So I think that's important for all of us to understand, that there is possibly no harm, even though.
Yeah. I think you need to understand that. But conversely, I mean, there are deaths on trials, right? And I'm not trying to be a downer or anything, but it can happen.
Yeah.
It's rare. There's always different reports coming out. It's typically something like 1%. So in the thousands and thousands of patients that are treated on trials, but it is something to be mindful of. We do, depending on how early the trial phases, I mean, the monitoring can be really intense, and it's all about making sure we're ensuring patient safety. And, all of these agents and trials have gone through, extensive vetting
Right.
by, at the FDA kind of nationally and even to the local IRB level to make sure that above all, patient safety is prioritized. And so I think you can feel comfortable in that process. But it is a risk, right? And the side effects can be simple, right? They can be like a little cough or, some nausea that you can treat with medications. It also could be blood clots, right? And you wind up in the hospital with, so there's definitely, those more severe risks are much more rare, but they're there, right? And if there's a risk of it, someone's going to get it probably, right? So we want to make sure we know who. And there's actually a lot of really cool research, and I don't want to go off on too much of a tangent, but trying to anticipate who gets those toxicities, because obviously that would be ideal if, in addition to understanding which patients stand to benefit the most from an agent, it would also really be great to know who is at the most risk from side effects, right? So I think that's an area of great interest and research as well.
Thank you for your candid comments on that. Much appreciated. So we briefly touched upon PARP, but we know that a lot more is happening in this space, right? And so you being an expert on this, can you tell us more about what's happening, what's the latest on PARP, and also which combination, there are quite a few, right, combination regimens with PARP, which is the most promising that's appearing to be in ovarian cancer, and are they applicable in all types of ovarian cancer?
Yeah, those are great questions. I think it's probably a little too soon to tell which combinations are the best. I think I can certainly tell you about some of my favorites. I really like the combination strategies that target DNA damage repair in two places, because I think what we've learned about targeted therapy in general is there are certainly some patients for whom, one agent is enough, but the majority will have the development of resistance in their tumor. And so if we can avoid that resistance by targeting two different pathways, within that same overarching DNA damage repair space, it makes sense that potentially we could avoid that resistance. And certainly we're also seeing the opportunity to overcome that resistance if it's already existing, to basically resensitize tumors. And some of the targets that I've already mentioned, like ATR, is of great interest. We published quite a bit on WEE1 inhibitors and their ability to do that. We're seeing different checkpoint inhibitors, as well as new novel agents like pol theta inhibitors. So there's a lot of really cool stuff out there that potentially has an opportunity to combine well with PARP and overcome resistance. I also think there are some new targets that may even be standalone, right? So maybe not even need to combine with PARP, but potentially overcome resistance in that space, by targeting other portions of the DNA damage repair pathway. So I think all of those are very exciting. Now, and of course, I'd be remiss if I didn't mention the combination of PARP inhibitors with immunotherapy and anti-angiogenics like bevacizumab, because we have 5 major trials that have all completed in the frontline setting, that we're waiting on data for. And of course, are hoping those data will be positive, because thousands of women were treated on those trials, and we want good results. So those will start reporting probably over the next year or two. I don't know when, but I think we've seen some kind of interesting small studies of the triple drug combination, especially, that seem to be active regardless of the presence of a BRCA mutation or HRD. So that's of course very exciting, because that's arguably one of the greatest unmet needs for patients with ovarian cancer is, what do we do when we don't have that biomarker, right? Especially in the upfront setting. And so, I'm very hopeful that that combination will be successful, and that will change the standard of care for patients with frontline disease.
Sounds like there's a lot coming up, and it's lots of things on the horizon, which is amazing. So thank you. So speaking of, we have talked about things that has worked, right? So let's talk about things that have not worked in terms of clinical trials or studies in progress. What should we know of the trials or the things that didn't work out, treatments that didn't work out for ovarian cancer, so we can all stay more, in knowledge as far as ovarian cancer?
Yeah, I mean, I think that that we've started seeing some of the novel agents get reported that we're hoping we're going to be positive that we're not. I think there is an agent called VB111, or gosh, I'm going to brutalize it, Offregene. I'm going to stop right there. But it was kind of a neat gene therapy that targeted both anti-angiogenic VEGF and stimulated the immune system. So it seemed like it was going to be a really cool strategy. And it was combined with weekly paclitaxel, which is the standard of care in platinum-resistant ovarian cancer. And unfortunately, it didn't meet the mark. And so I mentioned this only not to take that drug down, but there were some early studies that looked fairly promising, and enough so that a phase 3 trial was undertaken. But unfortunately, when that larger number of patients was treated, it didn't seem to offer any kind of improvement over the chemotherapy alone. So I think we're still waiting on results from a lot of other studies. I think I will mention that this is kind of an interesting story around the mirvetuximab agent that we mentioned. That's the antibody drug conjugate, or the targeted chemotherapy that targets folate receptor alpha. Initial studies of that drug were exciting, right? Early phase. And then they had a larger randomized study that actually was negative. And it's a testament to the investigators and to the company that they persisted, because what they realized was it was negative because of the way they were testing the tumors, and that they weren't, again, identifying the right patients that would benefit from the drug. So they went back to the drawing board, kind of revamped, reassessed their testing, and actually went back to an older test they were using that was better, and redid the trials. And so that's where we saw the Soraya data that were positive, because again, they selected the right patient, and that those are the data that are under review by the FDA, will hopefully achieve an approval. So I mentioned that not to say, oh, this drug doesn't work, but to say the initial studies weren't positive,
Right.
and they did a great job of saying, okay, let's regroup here, because we know this is a good drug, and instead of just flinging it out the window, let's reassess who we're treating and make sure we're treating the right patients. And it worked. So I think that's definitely a lesson learned, that it's not one size fits all, and that really selecting the right patient for the right drug for the right patient, or vice versa, is the right thing to do. In regards to what you were saying about kind of, do these agents kind of apply to all ovarian cancers, right? So I think that might have been in the last question, and I didn't cover it, but I'll just mention, I think this is where the excitement around utilizing molecular testing to guide therapy is really kind of borne out, because it doesn't necessarily matter the histology, right? We're starting to see more and more drugs that get approved just based on biomarker. And so we're really enthusiastic about getting kind of full testing for our patients, large amounts of sequencing across a number of genes, because if a patient has a rare abnormality for which there's a drug, that can change that patient's life, right? And I think that that's where some of the excitement is. So this potentially could reach beyond kind of the traditional kind of garden variety high-grade serous ovarian cancer, and instead, potentially be something that can be explored in low-grade serous or clear cell or other types. And so I think that's where kind of the promise of precision medicine is really exciting. And in fact, some of those rare tumor types have different abnormalities than high-grade serous, and they may have different other options for drugs for which we wouldn't use kind of for that high-grade serous population.
Thank you, Dr. Westin. As you were talking, I was thinking about this. Just a thought popped in my head. You are also in the endometrial space, big time, right? So there are patients who present with endometrial. I mean, it's not the majority, but there are a few, right? So that present with endometrial, but then progress to have ovarian cancer as a secondary, or vice versa. So first of all, how many patients do you see that off the top of your head that qualify for either, and then for those patients who have both endometrial and ovarian, do they do they have some unique characteristics that make them different in terms of the treatment options that you could offer to them? Talk to us a little bit about that.
Yeah, I mean, I think it's certainly it's not extensively common, but we do see it, right? Where people have both. It all depends on the stage of disease, right? So sometimes we see a patient with early stage endometrial cancer subsequently develop an ovarian cancer. Sometimes we diagnose them at the same time. Unfortunately, it can make it a little troublesome from trial enrollment standpoint, right? Because a lot of clinical trials will exclude patients that have multiple primary tumors. And so that, of course, is a consideration. Once if we're just treating somebody in kind of clinical practice, it involves kind of teasing out if there's metastatic disease or recurrent disease. Is it related? Which cancer is it related to? Which cancer are we treating, right? So, because that's going to guide, and there's a very different group of treatments for patients with metastatic endometrial cancer as compared to ovarian cancer. Although we start with paclitaxel and carboplatin, after that, they really kind of veer off into very different dimensions. And so some of the way that we can determine that is by getting, molecular testing on the metastases, or the areas that are outside of the primary, to understand, okay, this potentially is being driven by the endometrial cancer. This is being driven by the ovarian cancer. And what does that all mean? So it's a struggle, but that's where I think really making sure you're going to a center that has excellent pathology, so they can confirm that this is not all in fact related to one cancer, but is truly dual primaries, is really important. And then really getting that molecular testing to understand what the tumor may best respond to.
Yeah, I mean, definitely much more complex than treating one particular kind of cancer versus two primary versus one progressing to the other, like all different. I understand that. So you are also a surgeon, a very well-renowned surgeon. So talk to us about some of the surgical advances that are happening in the space recently, and tell us about your thoughts on the LANCE trial. And also tell us what LANCE is first, for those, and tell us about what you think.
Yeah, I mean, I think before I talk about LANCE, I think one of the other other surgical advances that we've been involved with, and Nicole Fleming has really been leading the way, is the identification of tumor intraoperatively. So what I mean by that is, for patients that have already received chemotherapy that are going for a subsequent surgery during their primary therapy, we often see, treated tumor, and there's always a struggle in understanding where there's active disease versus where it's maybe just old scar, and how extensive of a resection is necessary, because we always want to get to that goal of no gross residual. And so she's doing some great work utilizing different things like dyes that help us identify active tumor, or even something called the mass spec pen, which is we actually get protein readings, and based on the level, they can say, oh, that's cancer or that's not. So these are really novel new technologies that are still in trials, but potentially could be game changers for us as surgeons, so that we do what's necessary but don't do more than is needed, right? Because with every portion of the procedure, the risk goes up. And of course, we want to avoid things like bowel resections or spleen resections or things like that if it's not going to help the patient. We're happy to do it and we're ready to do it if it's going to lead to a better outcome. But if in fact that little nodule on the spleen is not active cancer, then this patient can retain her organ and have lower risk. So I think that's some of the stuff that's ongoing that's really exciting. And then Dr. Alejandro Rauhain is leading the Lance trial, which is looking at, in that same space, so patients that have had neoadjuvant chemotherapy and now need their interval tumor reductive surgery, is looking at understanding if we could do that surgery through minimally invasive techniques. So traditionally, this surgery has been a big open incision, usually from the pubis up almost to the ribs. And, an extensive resection is performed. But for some patients, for whom the imaging looks negative, right? It looks like all of the disease has gone away and their CA-125 is normalized. And there are some surgeons that have been doing this minimally invasively, which could be the right thing. But Dr. Rauhain, it's a testament to his excellent skill set that he said, you know what, we need to do the right study. We need to determine if we're helping patients or if we're missing things, and we're going to hurt patients with this. And so this is what his study is doing. So the Lance study is randomizing patients for that have, their tumors have responded very well to neoadjuvant, and they get randomized to either an open surgery or a minimally invasive surgery. And that can be done either, laparoscopically or utilizing the robotic system based on surgeon preference and patient preference. And so, and they're looking at outcomes to make sure that this isn't hurting patients. And so that's really exciting. I'm hopeful it's going to be positive. Obviously, we minimally invasive patients bounce back faster.
Sure.
They have less overall issues, although I think patients do very well with exploratory laparotomies now. We use something called enhanced recovery that has improved outcomes markedly. But any opportunity not to have a big incision, as long as it's, it's consistent and the outcomes are the same or better, that's what we want. So, we're, that trial's enrolling very well. It's open all over the world. And he is an excellent investigator. So we're really excited to see, what the results are for that.
Wonderful. So switching gears just a little bit. So this is a question that we have in mind for you, that if you were to connect over coffee with an overcomer, sitting down with a cup of coffee, what would you tell her about the state of ovarian cancer in 5 years?
It's a big question. I think that throughout this discussion today, I think I've told you about so many things that I'm really excited about and where we hold such great potential. So, my bottom line is I'm hopeful that, we're going to see patients living longer and hopefully curing more patients. I already think we're doing that, at least for the patients that have BRCA that are getting PARP inhibitors. So that's clearly a place where things have improved markedly, but we need to raise the bar for everyone else. And so I'm hopeful that some of these targeted agents that are, being explored in platinum resistant will potentially be able to give us better benefit in that upfront setting. And so I hope that over the next 5 years, we'll have seen greater strides across all patients with ovarian cancer, not, just those specific BRCA selected patients. And again, I'm very excited about what we've been able to do there, but I'm really hopeful that we'll have expanded that benefit across more of the population.
Wonderful. So this has been a great discussion. I am just curious to know that what's that one initiative on your whiteboard that you have now that wasn't there 30 days ago?
Well, I
Anything.
No, I'm going to tell you because I just took over, as you mentioned, as the center medical director. So I'm in charge of the clinic operations for the Gynecologic Oncology Center. And so my whiteboard is now filled with ways to improve our patients' experience as they're moving through their journey in our center, in our clinic. And so I definitely, any overcomers that are listening that are current MD Anderson patients, if you have some things that you would like changed, let me know so I can add it to my laundry list on the whiteboard that I'm trying to improve.
So your whiteboard is currently white and accepting all kinds of ideas
Well,
and
it's
inspirations.
already filling up, but it's got plenty of space
Right.
as I'm doing my learning tour of what's going right and what's going wrong. I definitely would love to get some patient experience.
Yeah, I didn't even know I asked you such a relevant question. Like,
Oh my gosh, so relevant. I was like, oh, this is great. I was like, I got a lot of thoughts about this one.
wonderful, wonderful. We wish you continued success in your new role, and we have ideas, so we'll be not shy in sending you all of those. So stay tuned on that. So thank you so much, Dr. Westin, for all your brilliant advice, information, guidance that you provided to us today. Just in closing, my last question, as always, what message of overcoming would you have for our audience?
We have a lot of reasons to have a lot of hope, and you deserve that. And so if you're not getting that where you are, you need to find a place where you can feel that, because that definitely has a huge impact on your overall outcomes. We need our mindset positive as we can. And so I think there's a lot of reasons to be positive for patients with ovarian cancer, and we're going to continue to push.
Thank you, Dr. Westin. Your ideas and your inspiration was very well appreciated and acknowledged, and we love your background. It's all festive and beautiful, just in time for the holiday season. And as you mentioned, this artwork was done by a child, a pediatric cancer patient, which makes it so much more special.
Yes.
So thank you for sharing that with us as well. So again, thank you for your time and your knowledge that you freely share with us each time. And again, you are our featured speaker for all seasons on all seasons. Connect over coffee. And overcomers, hope this was beneficial for you. I know I learned a lot from Dr. Westin, as I do every time she joins our episodes. And so keep watching and share this video far and wide with anyone who may benefit from all the great insights that Dr. Westin shared with us today. And we will be back with the next episode of Connect Over Coffee very soon. Until then, you keep overcoming. Thank you and bye.
Bye. Thanks for having me.